Hello, and welcome to the 2021 Newborn Screening Translational Research Network meeting. We are very pleased to be invited to participate in this workshop and to give you some opening comments and updates from the National Institutes of Health and the National Institute of Child Health and Human Diseases. And I'm pleased to introduce myself, Mellisa Parisi. I'm the Chief of the Intellectual and Developmental Disabilities Branch at NICHD, and my colleague, Mollie Miear, who is a program official also working at NICHD on our newborn screening portfolio. Today, we'd like to break our talk into two parts and give you a chance to hear two different voices as well. I'm going to start off and give some NIH updates, talk about a few of the initiatives that are currently ongoing and consuming a lot of our time at NIH, including the Unite initiative, some COVID-19 related activities, and a new recent workshop that has been hosted by NIH called Gene-Targeted Therapies. And then I'll turn it over to Dr. Miear, who will tell you about our NICHD strategic plan, the STRIVE initiative, and very importantly for this audience, several of our newborn screening initiatives. To start off with, what's going on at the National Institutes of Health? It turns out we've been very busy over the past year. And I think that some of these initiatives really reflect what's going on socially, what's going on as a country, and what's going on health-wise. And we can't ignore the fact that we are dealing with a number of crises in our country, not only with regard to the COVID-19 pandemic, but also with regard to issues around structural racism. In response to the social issues related to structural racism, which is pervading so many aspects of society today, NIH has launched the Unite initiative. And we're really trying to take this as very seriously as possible and really trying to change the culture of science that is supported by NIH and also change the culture of science within NIH and with the populations that we work with. So diversity has become a very important priority across NIH, and the Unite initiative is one way in which we are addressing this concern. So essentially, Unite is designed to identify and address structural racism. It's designed to establish an equitable and civil culture that will reduce barriers to racial equity in the biomedical research workforce and identify opportunities, make recommendations, and develop strategies that will increase inclusivity and diversity in science overall. And this is an initiative that is being supported at the highest levels of NIH leadership. In fact, there was a recent request for information that was promulgated through NIH channels, and our institute, the Child Health Institute, or NICHD, is signed on to an RFA on structural racism and discrimination with specific interest in our NICHD priority populations, which include individuals with intellectual delays and or disabilities, and many of our populations that are associated with newborn screening fall into this category. The due date is listed on this slide. And one of the things that we really want to reinforce around issues of diversity, equity, and inclusion is that simply saying that we've made the structures around us equal is not the same as really truly delivering equity. I think this slide illustrates really what we're talking about. Not just giving everybody a box to stand on to be able to potentially watch what's going on in the arena, but making sure that there are accommodations that allow for everybody to be able to equally participate in the activities. And that's really our focus with these activities. And something that we also think is very important with regard to establishing the investigator pipeline and ensuring that we support diversity among and within the trainees and the investigators across the spectrum of training, from undergraduates through graduate student, postdocs, early stage investigators, and established investigators. Because if we make an effort to ensure that there's representation at the earliest stages of career development, then we can ensure that by the time these individuals advance to become established investigators, we will have the workforce that reflects the diversity in our population. So I now like to pivot and talk a little bit about what we are doing with regard to COVID-19 initiatives that impact some of our communities of interest. And some of you may have heard of the RADx UP or RADx UP initiative. I'm going to tell you a little bit more about that and some of what we're doing, particularly with a focus on NICHD populations to support an efficient response to the COVID-19 pandemic. RADx stands for Rapid Acceleration of Diagnostics, and it has several different components. Some of these are really focused and have been focused on developing strategies and diagnostics around COVID-19. This also includes development of point of care diagnostic testing and radical approaches to really ensuring that testing is available for all populations. Now, the part of RADx that has been most interesting to NICHD is the RADx Underserved Populations or RADx UP initiative. And this is really trying to engage our communities and focusing on implementation strategies that will enable and enhance testing of COVID-19 in underserved and or vulnerable populations. One of the initiatives under the RADx UP program that is currently being developed is the Return to School initiative. This is focusing on children and adolescents below the age eligible for vaccination, which is currently age 12, and also looking at school personnel and really trying to make sure that we have a coordinated, integrated testing and vaccination program to basically help make sure that children across all different school settings, including community pediatric care clinics, child care centers, preschool, and regular elementary school, especially those serving underserved and vulnerable populations, can have access to school services. And we recently awarded 8 projects in April of 2021, totaling around $33 million. This is really being done under a research opportunity announcement, which allows for maximal flexibility. So now that vaccinations are starting to roll out, and we hope will be available for even younger children starting in the fall, we can incorporate that into some of these projects. And one of them is actually focusing on developing mitigation strategies that actually make sure that returning to school is safe for children with special needs, particularly those who may have a difficult time complying with mask mandates. So these and other projects are really trying to help ensure that the nation's children are really ready and able to return to school in the fall, regardless of where we are with regard to COVID-19 testing and vaccination. Another initiative that has been a very important one that is really looking at some of the long-term sequelae of infection by SARS-CoV-2. This is known as Pasc for Post-Acute Sequelae. And as part of the fiscal year 21 COVID relief bill, over $1 billion was allocated to NIH to support research related to long-term effects of COVID-19. This has really been a trans NIH effort because we recognize that up to 10% of individuals may have long-term symptoms of COVID-19 infection, and this may be exacerbated in at-risk populations, such as those that may have underlying genetic or metabolic disorders. So we are currently reviewing those applications and anticipate making awards that will help us understand better some of the long-term impact of COVID-19 infection. And then finally, I wanted to make sure that this community knows about 2 open funding opportunity announcements for COVID-19 research. And these are really looking at community-engaged COVID-19 testing interventions among underserved and vulnerable populations. This is phase 2 of the RADx UP initiative that was begun last fall, with applications due in early July. And then another RFA, which is really looking at the social, ethical, and behavioral implications of research on disparities in access to testing and vaccines in vulnerable and underserved populations, also due in early July. So check those out if you have an interest in COVID-19 related research. So those are 2 of the activities that have been pursued to help us really address some of the healthcare crises that are impacting our country. A different sort of trans NIH initiative that I would like to point out to you is an NIH workshop on gene-targeted therapies with a focus on early diagnosis and equitable delivery. This is a 3-day workshop being held under the auspices of NCATS and other institutes at NIH on 3 successive Thursdays in June. So at the time that you're watching this presentation, 2 of those presentations will have already been made. 2 of those workshops will have already been held. Day 1 defined who could benefit from gene-targeted therapies, the novel approaches that would be needed to enable development of these therapies, and when to optimally identify individuals who could benefit from these therapies. Day 2, which was held on June 10th, is identifying existing systems that can be leveraged or adapted to bring treatments to the individuals who could benefit from them. And day 3 will focus on identifying gaps that need to be addressed to make sure that these are effectively disseminated in an equitable manner to those who could benefit. And that will be held on June 17th. If you're interested in signing up, it's still available. It's free and open to the public. And the video cast links to the presentations are also available on the NIH website and are here. But I wanted to give you a little bit of a taste of what some of the discussions around gene-targeted therapies has been and how these might impact the newborn screening community. When we think about diagnosing disease, we think about, in most cases, a traditional medical model of clinical diagnosis. You have an individual, an unhappy stick person here in the middle of this circle who has a problem. They have a symptom or something that's not going well. They turn to a medical provider in step A who hopefully uses testing strategies, their own experience and that of other experts to make a clinical diagnosis. And then in step B, hopefully there are treatments available, drugs or other therapies or interventions that can treat the condition and solve the issue. So this is a problem-focused approach to medical diagnosis. In contrast, those of you in the newborn screening community recognize that this is a little bit different model that is really trying to identify at-risk individuals prior to the onset of symptoms. Newborn screening, of course, is prospectively testing all 4 million babies born in the US each year, and doing so through state-based public health programs, screening for many of these recommended conditions that are part of the recommended uniform screening panel, and that these are based on really having an effective diagnostic test, a population-based pilot screen, and a treatable disorder with a documented benefit that outweighs the risks of doing the screening. And most of these screens are based, as you know, on metabolic or biochemical assays. In some cases, confirmatory testing may include gene sequencing, but usually very focused on just a particular gene or genes of interest that are known to be associated with the condition that the baby might have had a positive screen for. When we're talking about a completely new paradigm, we're turning that on its head. This is a genotype first approach where you might start with a population of individuals and genotype all of those individuals to identify potentially pathogenic variants. Then those that are identified with likely disease phenotypes would then be identified and potentially have gene-targeted therapies that would be available to treat their condition. Now, obviously, we're not ready to go to this model today or even tomorrow, but we want to be thinking about a potential future vision that would be conceivable, that might be amenable for some of the new therapies that are becoming available with increasing frequency. And I think the newborn screening community, with its emphasis on early diagnosis and pre-symptomatic diagnosis in infants, has a lot to offer as we think about this new paradigm. And in particular, when we think about when would be the optimal time to actually make a diagnosis, we, of course, as part of this community, have an emphasis on diagnosis in the newborn period, the bottom red segment of this carousel. But you could envision a situation where there might be a genotype first approach, and that during childhood, there might be another opportunity to interrogate that genotype and see if there are conditions that could potentially be treated. And again, later at adulthood or at the time of preconception, or to identify potential carrier status. In addition, when someone has a partner and may be thinking about a pregnancy, there's another opportunity to potentially intervene using the information from the genotype to actually identify someone who might be at risk. So these are some of the ideas that are coming about as part of this gene-targeted therapies model of ways in which we can consider thinking about treating individuals who may have a genetic disorder. And we hope that some of these ideas will potentially come to fruition in the not too distant future. I'd now like to turn over this presentation to Dr. Mollie Miear, who will give you some updates from NICHD.
Thank you, Mellisa. So I'm going to quickly cover a little bit of information about NICHD's strategic plan and our STRIVE initiative, but I'm going to spend the bulk of my time talking about our newborn screening initiatives. So if you've not had a chance to check out NICHD's strategic plan, the URL is here on the slide, and I would highly encourage you to take a look because this is really laying out a new scientific mission and vision for the Institute, and all of our future research initiatives are going to be aligning with this strategic plan. And the document really outlines kind of 5 broad research themes, which are shown here, and outlines several cross-cutting topics that intersect with all of these themes, topics like health disparities or disease prevention. And newborn screening touches many of these research themes, especially numbers 3, 4, and 5. So again, take a look at this plan and don't be surprised if a program officer asks you how your proposed project aligns with the NICHD strategic plan. So in addition to the NIH-wide efforts to address structural racism, NICHD also wanted to focus inward and look at things that we could do within our own institute and our own scientific portfolio. And so our STRIVE initiative, which stands for Strategies to Enrich Inclusion and Achieve Equity, is really trying to address some of the underlying causes of health disparities like structural racism, as well as looking at ways to diversify the scientific workforce, not just within the broader extramural community, but also within NICHD. And STRIVE directly relates to many elements of our strategic plan and is really kind of focusing on 3 broad themes: equity, diversity, and inclusion in the NICHD workforce, enhancing the diversity of the extramural workforce and training programs, and addressing health disparities and systemic racism in scientific research. STRIVE is being led by NICHD's Office of Health Equity, and there are several committees within this initiative that are developing action plans that will be implemented over the next few years. And through STRIVE, what we're hoping to do is kind of get get an assessment of where we are, what we can do differently, and how we can kind of change things moving forward. So turning now to newborn screening, this audience is already well familiar with the importance of this activity as a public health program. Being able to provide a window of early intervention and treatment to help reduce morbidity and mortality for newborns. And there's a federal advisory committee, the ACH-DNC, that reviews nominations for new conditions to add to a recommended uniform newborn screening panel, or RUSP, which currently contains 35 core and 26 secondary conditions. NICHD is mandated to carry out, coordinate, and expand research in newborn screening under a program known as the Hunter-Kelly Newborn Screening Research Program. And these are the 4 big components of this program: identifying and developing promising new screening technologies, developing new treatments and management strategies, providing data and research that can be used to support the nomination of new conditions to be added to the RUSP, and conducting pilot studies on conditions that might be added to the RUSP. So the 3 kind of main categories through which we support newborn screening are shown here on this slide. So the first is what brings us all together here today is the Newborn Screening Translational Research Network, or NBSTRN. And this is an initiative in which we facilitate research on disorders by really supporting an infrastructure to provide resources to the newborn screening research community. We also support investigator-initiated research projects, And we also fund pilot studies for conditions that have recently been added to or have been recommended for adding to the RUSP. So through the NBSTRN, NICHD is really looking to facilitate research on conditions that are screenable in newborns, genetic and other congenital disorders. And through this research infrastructure, we really kind of are supporting a coordinating center for newborn screening research. And this is a contract that we have had in place since 2008 with the American College of Medical Genetics and Genomics. And one of the many tools that are hosted by the NBSTRN is the Longitudinal Pediatric Data Resource, or LPDR, which includes really helpful common data elements that have been validated that folks can use for designing studies. A really nice platform for data visualization and analysis. And then it also contains some really unique longitudinal cohorts that have both genomic and phenotypic data. So I'm sure you have all had a chance to visit the newly revamped NBSTRN website. And some of the data tools that are available through the site require you to create a free login account. So if you've not already done so, we would highly encourage you to do that. Things like the LPDR require a login account. One of the publicly available tools on the NBSTRN website is this NBS condition resource that provides information on conditions that NICHD is supporting research on. For example, there is a list of 37 conditions that has been identified by the NBSTRN as being promising candidates for future addition to the RUSP. So we support research on these types of conditions. A couple of active funding opportunity announcements that we have open right now include a PAR to support research to examine the natural history of disorders that are screenable in the newborn period. And this is with the R01 mechanism, and clinical trials are optional. And this is something that was recently renewed. So if you haven't had a chance to look at the updated version of this funding opportunity, please go check it out. And then we also recently published a notice of intent to publish a funding opportunity for innovative therapies and tools for screenable disorders in newborns. And the prior trio of FOAs for innovative therapies and tools expired in May of 2021, and we are in the process currently of renewing these PARs. So those are anticipated to come back out again this summer, and we encourage you to keep an eye on the NIH guide to find out when those get published. So NICHD, as I've mentioned, funds a number of pilot studies through contracts, and we issue task orders for different conditions that are being considered for addition to the RUSP, or in some cases, right after a condition has been added to the RUSP in order to continue building an evidence base to implement screening for that condition within a state screening setting. And so you can see here some of the past and ongoing pilot studies that we have funded over the years. And one example that I like to call out in particular is for SMA. And this is a condition most recently added to the RUSP in 2018. And you can see since it was added, 37 states are now screening for SMA. And that covers about 85% of all babies born in the United States. So that's a remarkably quick uptake for an addition of a new condition to the RUSP. And NICHD really supported a lot of the early research that helped pave the way for SMA to be added to the RUSP. So I'm going to go into a little bit of detail about the contract solicitation that we currently have open for funding pilot studies. And we use a contract mechanism to establish a pool of contractors who have the ability and capacity to perform pilot studies for screening of new conditions in a newborn screening setting. And NICHD selects the conditions that we would like to support through these contracts. And we do this using a contract mechanism called the IDIQ, which stands for Indefinite Delivery, Indefinite Quantity. And this is a really flexible contract mechanism that we can use that is sort of similar to an umbrella structure. So the IDIQ itself is kind of this overarching umbrella through which we support the pool of contractors. And then we issue specific task orders within that IDIQ for that pool of contractors to compete for, to do the various pilot studies. So the task order that we are currently soliciting for, in addition to being a member of this general pool of contractors, is to conduct pilot studies for MPS 2. And in the future, we will be issuing future task orders for pilots of new conditions. So why MPS 2? As you all know, this is a X-linked recessive condition and a closely related disorder. MPS type 1 is already a part of the ROSP. Currently, 2 states, Illinois and Missouri, have MPS 2 screening as part of their state screening programs. And importantly, there are available treatment options such as enzyme replacement therapy and hematopoietic stem cell transplantation. MPS 2 has been nominated for addition to the RUSP. In May, at its most recent meeting, the advisory committee voted to move the MPS 2 nomination forward for formal evidence review. So through the pilot study, we're hoping to continue to build the evidence base in support of addition of MPS 2 to the RUSP. So if you are interested in applying to be a part of this pool of contractors, the contract proposals are due July 1st by 4 p.m. Eastern Time. And we are anticipating that the awards will come out sometime in late September. The URL for the request for proposals is shown at the bottom of this slide. And when you go there, you'll find that there are different amendments where we update this solicitation over time. You'll want to keep checking back because as we receive questions from folks, we will be posting questions and answers as amendments in this RFP. So this will be updated frequently. One of the recent amendments that we published was a webinar that we held on June 2nd, kind of providing an overview of the IDIQ contract mechanism and some helpful tips for how to apply for the IDIQ. And pilot studies like those that we fund through contracts are really an important step for adding new conditions to the RUSP. And NICHD, in partnership with our federal partners, created this diagram to help illustrate the process of adding new conditions to the RUSP. And I'd like to thank Megan Phillips, who is part of our NBS team at NICHD, for all of her hard work for creating this diagram. In red, up above the funnel, are the parts that NIH and NICHD specifically help fund in order to build the evidence base for a nomination package that gets submitted to the Federal Advisory Committee. And this includes supporting research on basic science, screening assays, epidemiology surveillance, pilot studies, and development of new treatments. So we play a big role in a lot of the upstream work that happens before a condition can be added to the RUSP. And so with that, I would like to say thank you to the NBSTRN and the meeting organizers, and also acknowledge some of the other members of our NBS team at NICHD, Dr. Alice Cow and Megan Phillips. And with that, we would be happy to take your questions.